main takeaway from this study is that tricuspid valve regurgitation is a dynamic disease with a highly variable course, and it can progress or regress over time depending on the underlying conditions and comorbidities. My name is Vidhu Anand. I'm Associate Professor at the Mayo Clinic. The name of the article is Natural History of Tricuspid Valve Regurgitation, Understanding the Limitations of Medical Therapy. The study followed over 4,000 patients with moderate or more tricuspid regurgitation who were managed medically. At 1 year follow-up, about one-third of the patients showed regression of their TR severity, one-third had a stable course, and one-third either progressed or remained severe. The patients whose tricuspid regurgitation regressed had better survival outcomes compared to those who remained severe or progressed to severe. Factors such as atrial fibrillation, chronic kidney disease, and right-sided heart enlargement were associated with TR progression, while conditions like coronary artery disease, diabetes, and LV dysfunction were associated with regression. Nearly 50% patients in whom TR regressed to mild or less at 1 year follow-up again developed significant tricuspid regurgitation in the long term, despite guideline-directed treatment of the modifiable risk factors such as coronary disease, diabetes, and LV dysfunction. I believe the findings of this study have significant clinical implications. These results highlight the dynamic nature of TR, with disease severity varying over time. At the 1 year follow-up, we found that about a third of patients experienced regression, a third remained stable, and another third either progressed to or remained in the severe category. This variability underscores the importance of close monitoring, as those with persistent or progressive severe tricuspid regurgitation are at the highest risk of mortality. Currently, clinical guidelines do not provide specific follow-up recommendations for different tricuspid regurgitation subtypes, which makes our findings especially relevant. Given the unpredictable course of tricuspid regurgitation, with nearly half of the patients who initially improve seeing a recurrence of significant TR in the long term, it is clear that a one-size-fits-all approach won't work. Clinicians should consider regular follow-ups with optimization of medical therapy and echocardiographic monitoring at intervals no more than 12 months, especially for patients with moderate or greater tricuspid regurgitation. Furthermore, early identification of those whose tricuspid regurgitation is unlikely to improve with medical therapy alone is crucial. For these patients, timely consideration of surgical or percutaneous tricuspid valve interventions could make a significant difference in outcomes. Early intervention could potentially prevent further disease progression and improve long-term survival. For patients, the study highlights that severity and course of tricuspid regurgitation can change significantly over time. Even if their tricuspid regurgitation improves with medical therapy, nearly half may experience a return of significant tricuspid regurgitation in the long term. Once a diagnosis of moderate or severe tricuspid regurgitation is made, it is crucial for patients to understand the importance of close follow-up, both for optimizing medical therapy and detecting any worsening of the condition early on. Patients need to be aware that ongoing monitoring and possibly early intervention may be necessary to manage their condition effectively. For those whose tricuspid regurgitation does not improve with medication alone, timely discussions about further treatment options, including surgery or catheter-based therapies, may be crucial for better long-term outcomes. The next step is to validate these findings through multi-center community-based studies that include a more diverse population. Future research should also aim to identify more precise markers that can predict which patients are likely to experience progression or regression of their tricuspid regurgitation. Additionally, it's crucial to explore the long-term effects of both surgical and catheter-based treatments for tricuspid regurgitation, especially as transcatheter interventions continue to evolve and offer lower risk options for patients who may not be ideal candidates for surgery. There is also a strong need to study medical therapy both on its own and in combination with upfront surgical or percutaneous treatments. Medications like SGLT2 inhibitors and spironolactone, which are now approved for heart failure with preserved ejection fraction, have not been systematically studied in patients with tricuspid regurgitation. Ideally, they should be examined in a prospective randomized trial to better understand their role in treating this condition. I would like to invite you all to take a closer look at this article in the upcoming issue of Mayo Clinic Proceedings for further details.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings, or journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.